Hello everyone, we are going to start with a very important topic of the middle ear, that is the chronic mucosal otitis media. So basically we have the chronic suppurative otitis media. There are two types of the chronic suppurative otitis media. We have the safe type of the CSOM and we have the unsafe type of the CSOM. Safe type of the CSOM is also known as the chronic mucosal otitis media. We have the tubotympanic type of the otitis media. Unsafe is also called as the chronic squamosal type of the otitis media, the chronic squamosal otitis media, and it's also known as the atticoantral type of the CSOM. Atticoantral type of the CSOM. Now the thing is that these both are the CSOM. Now how to differentiate whether it's a safe CSOM and it's a unsafe CSOM? The thing is that जब भी हम safe CSOM के बारे में देखेंगे तो safe CSOM में usually there is a perforation which is a central perforation. Usually there is a central perforation. In the unsafe CSOM, there is a marginal perforation. There is a marginal perforation or the perforation present in the attic. Now we'll see in this diagram, there is a large central perforation which can be seen, which leads to this type of the CSOM, which is a chronic mucosal type of the otitis media. Let's get started. So chronic squamosal, that is a chronic suppurative otitis media में the chronic mucosal type. Why? Because the mucosa gets infected. Why? Because there's some perforation, any infection from outside goes inside, which affects the mucosa, and when it is going to affect the mucosa, it will cause a discharge. There will be discharge. The discharge will be there, and this discharge is a very it's a very mucopurulent, mucoid type of the discharge, which is non-foul smelling. There will be no smell, but it's a very profuse type of discharge, very mucoid, mucopurulent type of the discharge, which is occurring from the external infection, which goes into from externally, or it can be any infection from the eustachian tube or upper respiratory tract infection. That's why it's also called as the tubotympanic type of the CSOM. But in the other one, we have there is a perforation, but it's a marginal one. Whereas unless is eroded, there is a discharge, but that discharge is there due to the bone erosion processes, and that discharge is basically very foul smelling discharge is there, and that is a very scanty discharge. And due to this bone erosion processes, there can be a presence of bleeding also. You can see that there can be the presence of some amount of the bleeding which can be there. So in this we are going to have the discussion on the chronic mucosal otitis media and some introduction. Let's get started. So we have the chronic mucosal otitis media, the chronic suppurative otitis media. Let's have a main introduction, then we'll go to the CSOM, safe type. Chronic suppurative otitis media is a long-standing infection of a part. It can be a part or whole of the middle ear cleft, which is characterized by the ear discharge and a permanent perforation. So the first thing you have to understand, it can be a part, and it can be a whole of the middle ear cleft. Middle ear cleft includes the tympanic membrane, epitympanum, mesotympanum, or we can have hypotympanum, or it can be any aretus, antrum. We have the mastoid ear cells. So these are the eustachian tube. So that can be a part or whole of the ear cleft. And there is discharge is there, and there is a permanent perforation. When a perforation is said to be a permanent perforation, that is that whenever any perforation does not heal up to greater than 3 months, it leads to a perforation, which is the permanent perforation. A perforation becomes permanent when its edges are covered by the squamous epithelium and it does not heal spontaneously. A permanent perforation can be likened to a epithelium line fistulous tract. Epidemiology, let's have some basic points about the epidemiology also. Incidence of the CSOM is higher in the developing countries because of the poor socioeconomic standard, poor nutrition, lack of the health education. It affects both sexes and all the age groups. And in India, the overall prevalence rate is 46 and 16 persons per thousand in the rural and the urban populations respectively. It is also the single most important cause of the hearing impairment in the rural population. Types of the CSOM, very important. We have the two types of the CSOM, tubotympanic and the atticoantral. Let's have some discussion between the difference between the two. Tubotympanic, which is a safe type, which is a benign type. It involves the anterior-inferior part of the middle ear cleft. So anterior-inferior part of the middle ear cleft is going to be involved by it. That is the eustachian tube, the mesotympanum, and is associated with the central perforation. There is no risk of serious complications are there. Atticoantral, it's an unsafe type, which is a dangerous type, and it involves the posterior superior part of the cleft, that is attic, the antrum, and the mastoid, and is associated with an attic or the marginal perforation. So there was central perforation, here there is a marginal perforation, and disease is often associated with the bone eroding processes such as the cholesteatoma. What is cholesteatoma? It's a basically stratified squamous epithelium, which is usually present in the external ear or the external auditory canal, but not in the middle ear. Whenever that part is present in any of the temporal bone area, in any of the middle ear cleft. So this is basically the cholesteatoma. So what happens whenever there is any mass of this whitish mass of this cholesteatoma. Cholesteatoma is a whitish mass. There's a recruitment of macrophages to that area, and whenever the macrophages comes to that area, it causes the release of some enzymes like acid phosphatases, which causes the bone erosion processes, the destruction processes. And whenever there will be the bone erosion processes, of course there will be the risk of complication is very much higher in this variety. There will be the granulations, there will be the osteitis, which is going to be seen. So the first management has to be surgical whenever you see this atticoantral. The difference is that the discharge that you will get in the atticoantral is very scanty but very full smelling. There can be bleeding, and there can be granulation, there can be osteitis, and there is usually on examination you will see a perforation, which is a marginal perforation or the perforation present in the attic. Now this table, it's very important. That is a difference between the tubotympanic and the atticoantral type of the disease. Let's have some points in it. So we have the discharge. Discharge is usually profuse, mucoid, odorless, and that's a very scanty, purulent and foul-smelling discharge in the atticoantral or unsafe variety. Perforation is usually a central perforation. It's usually an attic or the marginal perforation. Granulations are very uncommon in case of the safe type, but they are common in case of the atticoantral one. Polyp, polyp occurs due to the chronic long-standing disease, which is usually a edematous middle layer mucosa, which from that there is a formation of the polyp, and these are, if present in the tubotympanic, these are pale, usually pale, which can be excluding out from that perforation, which is very pale you will look, but they are very red and fleshy in case of the atticoantral or the unsafe type. Cholesteatoma, that's absent in case of the tubotympanic. It's a very important characteristic of the atticoantral disease is this cholesteatoma, which is going to be present in case of the atticoantral disease. The complications very rare in you get in the tubotympanic one, but usually hearing loss. The hearing loss is seen in case of the tubotympanic one. The patient comes to you with a discharge and some amount of the hearing loss, which can be seen in this tubotympanic one. We have the complication, which is very common in case of the atticoantral or the unsafe type. Audiogram is a mild to moderate conductive deafness will be seen, conductive hearing loss, and in the audiogram you can have the conductive hearing loss as well as mixed deafness. Why? Because there is a bone erosion, so it can reach the inner ear also. It can affect the cochlea also, which can lead to the sensorineural hearing loss. With the sensorineural hearing loss and the conductive hearing loss, both can lead to the mixed type of the deafness. Let's start with the main topic, which is the tubotympanic safe type of the CSOM, also known as a chronic mucosal otitis media. Before that, let's have some discussion on the particular pattern of the classification of the chronic mucosal chronic otitis media. So it says that we have to have some introduction about this chronic otitis media. Always remember we have the chronic otitis media. Now this chronic otitis media can be, we have to get that we have chronic mucosal otitis media. We can have the chronic squamosal otitis media. This is the safe type of the CSOM, or this is the unsafe type of the CSOM. This is also known as the tubotympanic type of the CSOM. This is also called as the atticoantral type of the CSOM. Atticoantral type of the CSOM. So this table says that CMOM can be, the patient can come to you with the active disease or it can come to you with the inactive disease. So in the safe type, that is a mucosal disease, the active one, or it can come to inactive, or it can be a healed one. In case of the active disease, what you are going to get, the patient is coming to you with the discharge. At that time, this disease is the active disease. That is called as a chronic suppurative otitis media. And during the inactive disease, there is a perforation, central perforation. The patient is having a central perforation, but there are no symptoms of discharge. There is no purulent suppuration, infection, so there is no discharge, but there is a perforation. In the future, if there can be infection can occur. So this is the inactive disease in which there is a perforation is there, which is a permanent perforation is there, and we have the healed one. Sometimes the perforation heals on itself, so it can lead to the adhesive type of the otitis media, usually characterized by the tympanosclerosis, in which you will see the deposition of the calcium crystals behind that tympanic membrane. Next, the chronic squamosal, which is the unsafe disease. Like, what are the things that you're going to get? Now, in this you have to understand there can be, again, it can be active disease or it can be the inactive disease. Usually, in case of the inactive disease, there is a formation of the retraction pocket. One of the theories for the formation of the cholesteatoma states that cholesteatoma is formed due to the formation of the retraction pocket. So there is a negative pressure. This negative pressure leads to the formation of the retraction pocket, usually as the Prusak sac. Usually as the Prusak sac, where there is very much where the cholesteatoma is very much common. So that is a thing. That is in case of the inactive disease, you are going to get a retraction pocket. So during this inactive stage disease, when there is a retraction pocket, which we states at an inactive state of this chronic squamosal otitis media, you can just excise out this retraction pocket, or we have to basically regular cleanse this retraction pocket so that there should not be any debris of the keratinized epithelium or the squamous keratinized epithelium so that it can lead to that recruitment of macrophages and that bone erosion processes. So basically that is the inactive disease. That is, you will see on otoscopic finding that there is a retraction pocket. Yes, you are saying that the patient is suffering from chronic squamosal otitis media, but it's a inactive disease. But if there is a cholesteatoma, now you will see a whitish mass where that marginal perforation, there is bone erosion processes may be there. This is basically the active disease whenever there is cholesteatoma with the discharge, and this discharge is very scanty and very much foul smelling, or there can be a bleeding with. So this was a very interesting classification of the chronic otitis media. We have mucosal one, squamosal one. We'll see in the other video we have the chronic mucosal one. So let's start with this one, which is the tubotympanic one. So this tubotympanic is the etiology states that this disease starts in the childhood and is therefore common in that age group. It's a sequel of the acute otitis media, usually following exanthematous fever and leaving behind a very large central perforation is there. Ascending tract infection via the eustachian tube, that's why called as tubotympanic. Infection from tonsils, adenoids, infected sinuses may be responsible for the persistent or recurring otorrhea, and that is otorrhea ear discharge. Ascending infections to the middle ear occurs more easily in the presence of the infection. Persistent mucoid otorrhea is sometimes the result of the allergy to the ingestion such as milk, egg, fish, can be there. Now the pathology. Now pathology states that, what is the pathology? Like the tubotympanic disease remains localized to the mucosa, and that too mostly to the anterior-inferior part of the middle ear cleft. Like in any other chronic infection, the process of healing and destruction go hand in hand, and either of them may take advantage over the other depending upon the virulence of the organism and the resistance of the patient. Thus the acute exacerbations are not uncommon. The pathological changes seen in this type of the CSOM are with the perforation of the pars tensa. Now this perforation of the pars tensa that we are going to discuss about, it's basically a central perforation which can be vary on the size and position, and we have the middle ear mucosa. It's normal, but when the discharge is inactive or quiescent stage, it's edematous and velvety when the discharge is active. We have the polyp. This polyp is a smooth mass of the edematous and the inflamed mucosa which has protruded out through a perforation and presents in the external canal. It is usually pale in contrast to the pink fleshy polyp seen in the artichoantral type of the disease. So in the artichoantral you are going to get a very pink fleshy one, but if you are going to get a very pale type of the polyp, that's in the chronic mucosal otitis media. We have the ossicular chain. Ossicular chain is usually intact and mobile, but may show some degree of the necrosis, particularly of the long process of the incus. Why? Because the long process of the incus is there by, the thing is that end arteries meet here. Now we have to say perforation of the tympanic membrane. Of course, this perforation can be of the pars flaccida, attic perforation, which leads to the chronic squamosal, that is the unsafe type usually. Pars tensa central perforation is the one which is responsible for the safe type that we are discussing, that is usually responsible for the safe type of the disease. Like we can have anterior, posterior, inferior, subtotal. So basically anterior to the handle of malleus, we have the anterior, that is anterior to the handle of malleus. We have to say perforation is anterior, posterior is basically posterior to the handle of malleus, inferior to the handle of malleus is the inferior subtotal when very large perforation of the pars tensa with the parts of the pars tensa or annulus of the tympanic membrane are still preserved. The thing about the central perforation is that annulus has to be preserved. The marginal is that whenever there is destruction of the annulus or the perforation destroys the annulus and reaches the sulcus tympanicus, it may be a posterior superior, anterior, inferior, total, or the posterior superior marginal perforation is the most common, which is responsible for the cholesteatoma formation. So this is a very important thing, like which type of the marginal perforation is very common, that is a posterior superior marginal perforation. Next we can have the tympanosclerosis, which is the hyalinization and subsequent calcification of the subepithelial connective tissue. It is seen in the remnants of the tympanic membrane or under the mucosa of the middle ear. It is seen as white chalky deposits on the promontory, ossicles, joints, tendons, and oval and round windows. The tympanosclerotic masses may interfere with the mobility of the structures and cause the conductive deafness. Where the fibrosis and adhesions, they are results of the healing processes and may further impair the mobility of the ossicular chain or block the eustachian tube. Where the tympanosclerosis, which is a hyalinization, we have discussed about this. We have the fibrosis and adhesion thus. Now the bacteriology, like what is the basically bacteria responsible for this? Pus culture, that is very important in both types of the aerobic and anaerobic. CSOM may show multiple organisms. Common aerobic organisms involving are Pseudomonas aeruginosa, we have Proteus, we have E. coli, we have the Staph aureus, Staphylococcus aureus, while the anaerobes includes Bacteroides fragilis and anaerobic streptococci is there. Now these are the various perforations. That is a central perforation. So then we have the central, that is a central perforation anterior. Then we have the medium sized one. Then we can have the subtotal perforation. Then we can have the total perforation with the destruction of ear and the annulus. We have the attic perforation and the posterior superior marginal perforation. So it says that perforation of the tympanic membrane, attic and posterior superior marginal perforation, are seen in the dangerous type of the CSOM. This is very important. They are usually seen in the dangerous type of the CSOM and are often associated with the cholesteatoma. Stratified squamous epithelium from the external auditory canal can grow into the middle ear in any type of the marginal perforation by immigration and form a cholesteatoma. Therefore, all the marginal perforation are considered dangerous. The central perforation are considered safe, as the cholesteatomas are usually not associated with them. Now, the clinical features of the safe type of the CSOM is the ear discharge, perforation, and the hearing loss. The first is the ear discharge. It is non-offensive, mucoid, non-mucopurulent, and constant or intermittent. The discharge appears mostly at the time of the upper respiratory tract infection or on an accidental entry of the water into the ear. Hearing loss, it's a conductive type of the hearing loss. Severity varies but rarely exceeds 15 decibels. Sometimes the patient reports of a paradoxical effects, that is, hear better in the presence of the discharge than when the ear is dry, because the round window shielding effect. It's very important. Like, what is a round window shielding effect? Like, whenever there is a discharge, so it's whenever there is a discharge, patient hear better. Why? Because whenever there is a discharge, what is going to happen? The discharge, which helps to maintain the phase difference. Why? Because it covers the round window. The discharge covers the round window, and so when the discharge covers the round window, there is a phase difference is going to maintain, which causes a better hearing during the time of the discharge. In the dry ear with the perforation, sound waves strike both of the oval and round windows simultaneously, thus cancelling each other effect. Now, in long-standing cases, cochlea may be suffered damage due to the absorption of the toxin from the oval and round window, which can lead to the hearing loss. That is a mixed type, because conductive hearing losses occurred. It can lead to the sensorineural hearing loss, thus resulting in a mixed type of the hearing loss. Perforation is there, always central is there. It lies anterior, posterior, inferior to the handle of Malleus. It may be small, medium, or large, or extending up to the annulus, that is subtotal. We have the middle ear mucosa, which is seen when the perforation is large. Normally it is pale pink and moist, and when inflamed it looks red, edematous, and swollen. Occasionally a polyp may be seen. If seen, it will be a pale one. Now, assessment. So they are going to ask you the clinical features, which are 3. You are going to get the discharge, you are going to get hearing loss, and you are going to get a central perforation. Next, the thing is that what is the assessments that you have to do? Sabse pehle you have to examination under the microscope. Okay, that is for the culture sensitivity, and that is very important. It is essential in every case and provides useful information regarding the presence of the granulation, in growth of the squamous epithelium from the edges of the perforation, status of the ossicular chain, tympanosclerosis, addition. तो ये सब हम examination under the microscope से लगा सकते हैं पता. An ear which appears dry may show some hidden discharge under the microscope. Rarely cholesteatoma may be coexist with the central perforation and can be seen under a microscope. Now, the audiogram, which is very important. It's given assessment of the degree of the hearing loss and its type. Usually the loss is conductive type, but a sensorineural element may be present. Culture and sensitivity of the ear discharge. It helps to select the proper antibiotic ear drops that can be needed. Mastoid X-rays, CT scans of the temporal bones can be done. Mastoid is usually sclerotic but may be pneumatized with the clouding of the ear cells. There is no evidence of the bone destruction. Presence of the bone destruction. It's a very important feature of the aticoantral type of the cholesteatoma or aticoantral type of the disease. Let's start about the treatment. Now, treatment, you have to discuss about the treatment. Now, that depends whether it's an active disease or whether it's an inactive disease. Firstly, if it's an active disease, whenever there is a discharge, the aim is to control the infection and eliminate the ear discharge, and at a later stage to correct the hearing loss by the surgical means. The first thing is that if the patient is coming to you with the active disease, that there is a discharge from the ear, then you have to do the oral toilet, that is, remove all the discharge and debris from the ear. It can be done by dry mopping with the absorbent cotton bud suction clearance under the microscope, or the irrigation, non-forceful syringing with the sterile normal saline. Ear must be dried after the irrigation. First you have to dry the ear. After that you are going to provide the ear drop. Why? Because it's a chronic suppurative disease. Because it's an active one, you have to give the antibiotics. Ear drops containing the neomycin, polymyxin, chloromycetin, or the gentamicin are used. They're combined with the steroids, which have local anti-inflammatory effect. To use the ear drops, patient lies down with the disease ear up antibiotic drops are instilled and then intermittent pressure applied on the tragus for an antibiotic solution to reach the middle ear. This should be done 3 or 4 times a day. Acid pH helps to eliminate the pseudomonas infection, because this is a main organism responsible for the CSOM. And the irrigations with 1.5% acetic acid are useful. Care should be taken as eardrops are likely to cause the maceration of the canal skin, local allergies, growth of the fungus, or the resistance of the organism. Some eardrops are potentially ototoxic. Next, we have the systemic antibiotics that are important. They are useful in acute exacerbation of chronically infected ear. Otherwise, role of the systemic antibiotics in the treatment of the CSOM is limited. Now, what is a precaution? Precaution, after that, you have to say that patients are instructed to keep the water out of the ear during bathing, swimming, hair wash. Rubber inserts can be used. Hard nose blowing can also push the infection from the nasopharynx to the middle ear and should be avoided. Treatment of the contributory cause, attention should be paid to the concomitantly the infected tonsils, the adenoids, we have the maxillary antra, and the nasal allergies. Then we have the surgical. Now you have treated that active disease. Now there is a surgical treatment. The surgical treatment is basically very good treatment for CMM. Is basically we have tympanoplasty, which involves the ossiculoplasty plus, that is, myringoplasty. Firstly, you have to take out the status of the ossicular chain. If it's good, you can do just myringoplasty, that is a repairment of the tympanic membrane. But if there is the necrosis of the ossicular chain, you have to repair the ossicular chain, and that is known as the ossiculoplasty. Then you have to repair the myringoplasty. Then you have to go with the myringoplasty, repair the tympanic membrane. That's why the ossiculoplasty plus the myringoplasty equals to the tympanoplasty. So the tympanoplasty is a mainstay of the treatment as a surgical treatment for the chronic mucosal otitis media. Surgical treatment, oral polyps or the granulations, if present, should be removed before the local treatment with the antibiotics. It will facilitate ear toilet and permits the eardrops to be used effectively. An oral polyp should never be avulsed, as it may be arising from the stapes, facial nerve, or the horizontal canal, thus leads to the facial paralysis or labyrinthitis. We have the reconstructive surgeries once the ear is dry. The myringoplasty, with or without the ossicular reconstruction, that depends upon the status of the ossicular chain, can be done to restore the hearing. Closure of the perforation will also check the repeated infection from the external canal. So that was about this thing, but the mainstay of the treatment lies with the tympanoplasty. In the tympanoplasty, we have the tympanoplasty. The tympanoplasty is there, which is the ossiculoplasty plus the myringoplasty. That's the mainstay of the treatment. You have to always remember that you have to check for that. Basically check for the ossicular status. You can do a test also that is called as a patch test. So patch test can also be done to see that if there is any damage to the ossicular chain or not. So this was about our CSOM, which is a safe type of the CSOM. So okay, bye bye.